Good morning, everyone. It's a honor and pleasure to be here. All right. This is a lovely memory from the TNOA here in Pondicherry, and my connect with uh, Pondicherry or Tamil Nadu as an extension date backs from my residency in CMC Vellore. Dr. Usha Kim has been a teacher to us since the time I was a fellow. Today, our daughter studies in Jipmer, Pondicherry, so a lot of connections, and always a pleasure to be a part of any activity at Arvind. I'm very impressed with the minimalism and the sustenance policies here. Lots of wonderful things going on in innovation, and I'm honored to be a part of this meeting. Quickly, let us look at the disease spectrum or the topic of inflammation, which is specific, and we call it thyroid eye disease. So for me personally, the whole thyroid story started long back in 2004. I'd just completed my fellowship, and there was this old lady who told me that I need a surgery because my eyes are prominent. And I was wondering at the fag end of her life, why does she want this operation? Um, why couldn't she just cover her eyes with dark glasses? And she told me that her grandchildren are scared of her, and that's why she wants the surgery. That was the trigger point for interest in this particular subject. Subsequently, I was fortunate to get specific training at UCLA, and many of the innovations in thyroid eye disease originate from this place. And I was fortunate to work with all those people on several projects, particularly the immunology and the understanding of this inflammatory disorder. Several teachers over the years have shaped my understanding of the subject. And initially, when I came back after my fellowship, I thought that I would see the kind of absolutely inflamed thyroid eye disease patients which I saw there when I was doing my fellowship. And this is what I expected to see in every patient in India. But what I ended up seeing more often were the patients who barely had any inflammation, if at all. And when they really had inflammatory signs, the problem was unique, which was not really described in the Western textbook. So, how is thyroid eye disease different from the other immunological diseases like rheumatoid, Crohn's? There are several. That the inflammatory activity in these other disorders, it continues, it waxes and wanes throughout the life. Whereas in thyroid, this period is finite. And after that finite period, which is 12 to 18 months, the eye or the inflammatory components, they become inactive. And that's the reason why in these patients we have active phase and an inactive phase of the disease. So during the active phase, we'll have all inflammatory signs, and in the inactive phase, those inflammatory signs will disappear. What will remain is the proptosis, the lid retraction, maybe the strabismus. And all hypo, as well as euthyroidism is involved or associated with thyroid eye disease. So this is how a Rundle's curve is. This is a curve which represents the inflammation in these patients. So there is a peak where the inflammatory signs are to their maximum, and then it flattens out, and finally it reaches a stable level. Maybe not to the baseline, but to a stable low level. So to me, TED is a clinical diagnosis. The classic findings, lid signs, the proptosis, which is bilateral, is pathognomonic. You don't actually need a CT or a B scan to diagnose this. And as a resident, or even sometimes as a fellow, a lot of us might confuse between what is severity and what is activity. So severity is the change in the measurement. So the proptosis here could be labeled as mild, moderate, and severe based on my hurdles, or I could label lid retraction as mild, moderate, and severe based on my measurements. Activity, on the other hand, is a score that is given as objective as possible. And that actually defines what are the pro-inflammatory signs. And here is an example of the clinical activity scores being 0 and absolutely white eye to 4 and 5, where you have several obvious signs of inflammation. And this is a classic paper by Moritz MP, who described this simplistic method of assessing clinical activity score. There are other methods too. There was a multicentric trial which we were involved in to try and objectivize the scoring system. So when I started looking at epidemiology, why am I not seeing these classic inflammatory patients? When I came back, I looked at what literature do we already have in our country. And I found only this one paper which talked about what's the prevalence of Graves in patients who are visiting an endocrinology clinic. So the prevalence was around 1/3, and sight-threatening disease was 2%. So the unanswered questions of what kind of TD profile do we have, I never really saw a child with thyroid eye disease in India. So what's the percentage of that? Then very few patients who actually need strabismus help. So in the US, it's a very common concept to have a common clinic where you have a pediatric, where you have a strabismologist, oculoplastic surgeon, a rheumatologist, and they combined see a thyroid patient. And when I just blindly thought of replicating that, I realized that the cases where I actually need strabismology help is not as many, which justifies having this kind of a clinic. So I got an inkling that maybe what we see here must be slightly different. But that was, at that point of time, just a hunch. Here are many ways in which a patient can have redness when you are having thyroid eye disease. And I call it pseudo activity, because oftentimes the fellow will label the patient as thyroid eye disease and would even write a plan for steroids, whereas it may not actually be activity. One of them is corneal issues, which can cause inflammation in that eye. And this is an extreme obvious example of an infiltrate. You could have something less sinister than that. Congestion can sometimes be only in the palpebral fissure. So if you look at their superior or inferior limbus, the eye is white. But these are typically patients who have lid retraction, and it's the palpebral aperture which is most exposed, and that's why it's most red. You can have just pure episcleral congestion, the kind of one which makes you suspect of a carotid cavernous fistula. This could be due to a full orbit, particularly muscle disease. So just a warning that every red eye is not inflamed orbit or active thyroid eye disease. So we have to really look at the timelines of the patient. So this was the multicentric study we were talking about, where we tried to look at what is the reliability of the scoring system that we use. This tried to make it more objective beyond Moritz MP's publication. And then we reported our series, hospital-based series of 1,000 patients, where we found that almost 1/3 of them are silent presenters. And by that, we mean they do not have inflammatory signs, but they are actually in that initial 12 to 18 months disease activity period. And we also found that many of these patients, almost again 1/3, are euthyroid. So here is a comparison with some of the other studies talking about the age representation, pediatric being less common, and also the classic female to male ratio, which all the Western books talk about. Sorry. As we move studies from the West towards the East, you will see that this relationship starts to drop down. Here you can see 3 and 4 in the UK, Canada, and the USA. Thank you so much. But as you move towards Singapore, Malaysia, you will see that the disease is not as common in females as in the West. And our hospital-based data was actually reversed, where we found it to be more common in male. Now, that could be a referral bias. It's a tertiary care center, but there is no doubt that this trend as we move towards East does change. So there is something different about this disease when you move to the East. Again, laterality, unilateral cases are more common in our population. So overall, what is more common in our population is silent presenters, patients who are euthyroid, so their blood levels will absolutely be normal. That confuses the patient as to why am I having thyroid eye disease then if I don't have blood levels abnormal. So in summary, I started looking at these patients as not really with the inflammatory signs, but more with their timelines. And then we even went ahead very recently and compared prospectively a cohort from our country and that from the Rochester University. And we found that there is a distinct difference between these two cohorts. So our subject population is distinctly different from the others. Talking about sight-threatening disease, of course, dysthyroid optic neuropathy is one of the primary reasons. But in our population, infiltrates is also a second cause. And we looked at this as to why this could be happening. What are the risk factors for someone to develop microbial keratitis when they are having thyroid eye disease? And severe eyelid retraction and motility restriction were the obvious risk factors there. These are all examples from the paper that we had published, how in these patients just a tarsorrhaphy often doesn't help, and you might have to recess the levator along with the tarsorrhaphy. A couple of points about the surgical advantages as we went over the years to refine the procedure. We also looked at the benefits of sonopet, which preferentially targets bone and it spares the soft tissue. Now, the advantage of this was particularly in the floor decompression, where you could spare the infraorbital nerve and reduce the incidence of hypoesthesia. Here we are showing a video of navigation guided decompression, where the navigation gives you real-time information as to where you are in the orbit, so that you can actually have the benefit of being very accurate as well as safe. This paper talked about how piezoelectric technology can reduce the incidence of hypoesthesia as compared to a mechanized drill. And this is particularly applicable to the floor decom, where the infraorbital nerve can literally have a lot of postoperative morbidity in terms of lip and the V2 anesthesia that they can have. Lastly, talking about particularly the ptosis in thyroid eye disease, most of us associate thyroid eye disease with lid retraction. Like that's the classical sign. And when we think of ptosis in thyroid, we almost always think about myasthenia. And that's what the textbooks speak about. Most publications focus on myasthenia in this. But when we looked at our 1,000 cohort and we segregated the patients who had ptosis, we found that 2/3 of them were actually levator disinsertions. And a slightly increased population amongst those 2/3 were the patients who had predominantly fat disease. So there's excess fat in the orbit, and that is what is predisposing the levator to get disinserted, much like how you give a peribulbar block and that whole swelling actually induces a ptosis formation in a patient who's already predisposed. So apart from the fact that aponeurotic was found to be more common, we also in the same series reported how we can combine decompression surgery with a levator reattachment, just like how decompression and lid retraction is more and more being treated simultaneously. A little bit about imaging. We have a talk on radiology, so I will not touch upon it more, but many a times these measurements matter less and the configuration of the muscle matters more for the oculoplastic surgeon. And between these two, if I have a surgical planning to be done, I would prefer a CT scan. So I would do imaging only if my diagnosis is suspect, or if I suspect compressive neuropathy, or if I'm planning a surgery. Lastly, talking about this disease and its social impact, we also created a website where patients can have basic information, and they can even request to contact another patient who has gone through the thyroid eye disease so that they can actually speak to them. And this is kind of a support group between patients. And I find this to be very useful for patients who are horrified with this diagnosis. So my simplified approach in these patients is for the ones who are very mild disease, clinical activity zero. I treat it very similar to what an obstetrician does to a normal pregnancy. Just follow up regular checkups. I give steroids only when there is compressive optic neuropathy or disfiguring inflammation, which threatens the cornea. And finally, the paradigm does remain the same, where we start with proptosis, strabismus, eyelid, although we are trying to combine more and more of these into one at the same time. So with that, I will stop because we do have a topic on the surgicals. But just to summarize, we had discussed by now hospital-based epidemiologic data and what all are the advocacy and the changes that occurred in our approach based on what we found as the findings in thyroid eye disease. Thank you very much.